Okay, hello everyone. Welcome to plenary PS 2.2, Harnessing Technology to Achieve Equitable Outcomes. So I'm Keisha Prem and I'm from the National University of Singapore. And it's really lovely to sort of see you join us for this session. Do come in, do stream in, and find a seat towards the front of the session. So I think we are truly fortunate to just come immediately after, I would say, one of the most impactful plenaries so far. One of the interventions that really stuck with me by one of the panelists earlier was really on the fact that we talk about rights to health, and that's great, that's important. But what's truly important here is access to health. And I think this session here immediately speaks upon that. Like, how do we ensure that we get access to help to the right people out there? So we talked about technological changes and digital health technologies, all those different tools out there. So all of these innovations are advancing rapidly, and their successes as public health solutions depends on actually the effectiveness, cost sustainability, accessibility, and equitable outcomes. So beyond availability, access actually really matters more. Many health technologies exist, but their impact is limited if they actually do not reach the population that needs them the most. So expensive individualized health solutions, as what Osama mentioned earlier, you need to actually really weigh them against global public health goods. For example, vaccines, which are a leveler in today's world. If the vaccines are affordable, the vaccines are accessible, that can actually ensure that there are equitable health outcomes. There are also regulatory challenges. For example, non-traditional producers with fragmented regulations, and they find it difficult to enter the market. So we're going to be discussing a little bit about that later on. There is also an important need to understand what the users need. So technology need to be more user-centric to ensure that they solve real-world problems rather than really what problems you see behind the computer screen. So I think right now it's my pleasure to introduce our distinguished panelists, each of whom brings a deep expertise in leveraging technology for health equity. So we have Dr. Nada Malu from the Medicine Sans Frontier, who will be sharing a little bit more later on. We have Chioma Wachuku, who is from Gavi. We have Chayaton Limapanovic from National Innovation Agency in Thailand. We have Alexio Esperato from the Asian Development Bank, and we have Suhail Bidani from the Gates Foundation. So together, our panelists brings a wealth of experience in health technology, policy, and innovation. And I'm excited to dive into today's discussion with them. So the very first speaker we have today is Dr. Nada Malu, who is in the Antibiogo Program Manager at Medicine Sans Frontier. Nada has spent over 15 years supporting access to diagnostics in low and middle income countries to combat antimicrobial resistance. She led the development of a technology, a groundbreaking smartphone-based digital tool, which became the first CE marked software as a digital medical device designed specifically for LMICs. So without further ado, Nada, may I invite you over to share a little bit more about it? Thank you.
Thank you very much. Hi, everybody. Thank you very much for having me with you today. It's really my pleasure to share our experience in Médecins Sans Frontières. So we will be spending 2 hours together with our colleague. And during my speech, I will try to use a specific use case of Antibiogo, which is a software as medical device developed by Médecins Sans Frontières or Doctors Without Borders. So very quickly, Médecins Sans Frontières is a humanitarian medical organization. We intervene in more than 70 countries. We provide care for population who are affected by natural disaster, by outbreaks, and population who are excluded from the healthcare system. And so I start the talk with the question, like, is it normal that a humanitarian medical organization, an NGO, decided from a day to another to become a legal manufacturer for a digital health tool? I think it illustrates also the gap in terms of need and understanding of the need in some of the countries where we intervene. Just to be clear, we are mainly intervening in affected region like Middle East, where countries where conflict are important, from Yemen to Iraq, Syria, Gaza, but also in a lot of countries in West and East Africa. And in those regions, usually access to the population, the need of the population, but also the user is quite challenging. And as a humanitarian organization who intervene in this region, we were lucky to have access to those populations and try to understand the need and how we can respond to this need through digital health tools. So when we speak about the different health disease and issues that we try to let's say, resolve within Médecins Sans Frontières, people used to think that we are an organization that mainly work in refugees camp, managing outbreaks like cholera and Ebola, but we also manage issues and public health threats like antimicrobial resistance. Today, you all know that antimicrobial resistance is one of the major public health threats. We are observing a shortage in antibiotics that are effective to treat simple infections. In order to ensure accurate access to antibiotic treatment and to improve the rational use of antibiotics, there is a need to have access to diagnostic. Unfortunately, 47% of the global population has a little no access to diagnostic and especially microbiology diagnostic. For antimicrobial resistance, the WHO estimate that if we don't act today, we will end up by 10 million deaths per year by 2050. And if you look to the map and the distribution of the death, we have the majority of the deaths that are going to be in the African and the Asian continent. So in order to have access to diagnostic, we need to have human resources who are trained to perform the test, but also to make the interpretation of those tests. Through MSF experience implementing access to microbiology in different countries, especially in difficult settings like Yemen, Gaza, Iraq, Syria, but also in West Africa, what we observe is that there is no human resources like clinical microbiologists or pathologists, but it's quite easy to train laboratory technicians, for example, to perform the test, but much more complicated to train them to make the interpretation of this test. And as a microbiologist, I can tell you, sometimes it's better to do not have access to diagnostic than having access to a non-accurate diagnostic. This observation was confirmed by this amazing publication in The Lancet, describing that in sub-Saharan Africa, if we want to have the same ratio population microbiologists than in US and Canada, we need 400 years of training. So you have 10 million deaths by 2050 and 400 years of training. And that's how the idea of antibiogo came. So very quickly, this is the test that is the most important to tackle AMR. It's the test that will provide the list of antibiotics that are effective and that can be used to treat the patient. These tests need to be interpreted. There is like 10,000 rules that are changing every year from the European or the American Society of Clinical Microbiology. And this is what the microbiologist does. So we created a smartphone-based application that is free, that works offline, so you don't need internet connection after downloading it, to support laboratory technicians to read and make the interpretation of those antimicrobial susceptibility tests. It's basically what was described also by other colleagues yesterday. It's a task shifting that we are trying to achieve through the development of this tool. So you can imagine that a humanitarian organization is not really expert in the development of such technology. And that's why it was a very interesting adventure. We collaborate with academic, with, of course, health stakeholders, regulatory, and with tech stakeholders. We were lucky enough to win the Google AI Challenge. So we had the support of Google for 1 year, also through Googlers developing and working with us. And it was an interesting experience because we had to create a world where all the different fields find the same communication, and we build the bridge between those different words. So today, Antibiogo was audited by the WHO as part of the Compendium for Innovation for Low and Middle Income Countries, and we were very happy to see the technology recommended as the technology that can be used for LMIC. Today, antibiogo is used by Minister of Health in public laboratories in different countries, from Jordan to Yemen, Afghanistan, Mozambique, Burkina Faso, and there are others that are coming. So in order to scale up, we are mainly collaborating with national authority and Ministry of Health. So I will finish my speech because I heard the bell. So for antibiogo, what's coming next? Because we finished the development of the majority of the software. We perform the regulatory process, and we got the CE marking in 2022. And right now we are transitioning from the IVD directive to the IVD regulation in Europe. But this is just the beginning. And this is my conclusion, and it's really a message that I want to share with you, is that the development of such tools, it took us 6 to 7 years, but what is coming in the coming years regarding the maintenance, the sustainability, and the scale-up is the most challenging part, because there is no model or mechanism for such tool for low and middle income countries. We'll have to continue to refactor the software, the IT software. We have to perform post-market surveillance. We have to collect user feedback in order to iterate, in order always to have this tool relevant for the user that we are targeting in LMIC. And we need to be also able to support the user to troubleshoot if there is any issue with this diagnostic tool. So it's my question for all of you today, and I'll be happy to discuss that for the coming 2 hours and with my colleague. I am too young, and so I did not experience the diagnostic, let's say, revolution that we had in the 50s. Today, we are experiencing, and we are lucky enough to be in the middle of this digital transformation and revolution. So from our perspective, we think that we should avoid repeating the same mistake that we made regarding access to treatment and diagnostic in the past. And we must look forward and learn from those past experiences to ensure that digital health technology reduce inequity. We need to think ahead about specific funding mechanism in order to sustain those technology and always keep them relevant. Otherwise, we will end up with a huge list of digital health tool and software as medical device available, but not sustained. And one will, let's say, erase the other one. And we don't think that it's a rational use of the resources. So very happy to discuss this point with all of you for the 2 coming hours. Yeah. Thank you very much.
Thank you so much, Nada. I think you raised a really good point, which we'll pick up during the panel discussion as well. Next, without further ado, can I get Dr. Chioma Wachuku, from Head of Public Policy Engagement Regions and Countries at Gavi, the Vaccine Alliance. And she works at the intersection of policy, global health, and immunization access to ensure that vaccines, which is a technology, by the way, reach the communities that need them the most. So over to you, Chioma.
Thanks so much, Keisha. Morning, everyone. Just first of all, I'd like to thank PMAC for inviting Gavi in this conversation. And for us, we're really excited to want to be here to share our perspective, but to also bring the perspective of what we're doing in low and middle income countries. I'll primarily focus from the angle of equity. If you look back 25 years ago, when you look at the landscape, there were many great innovations in terms of responses to like maybe pneumonia, measles, but a lot of the low-income countries didn't have access to these vaccines. And this was a problem because, one, it was a pricing issue, and this spurred on the creation of Gavi, whereby we have a powerful mission, which is really focused on addressing these inequities, making sure that no child is left out because of where they live or where they're born. And our vision is really around how do we make sure vaccines are accessible. So from that equity point of view, we work through our model, which is a public-private partnership. And I'll just walk everyone through real quickly. We bring together to the table, we have the Bill and Melinda Gates, the Gates Foundation. Then you have WHO, UNICEF, our technical partners, civil society, private sector, but also research and development. And this aspect allows us to bring the best skills and experiences to really figure out what's the best way to support countries to deliver vaccines. One aspect is shaping the market, but the other reality is that vaccines don't deliver on their own. So to do that, we are also involved in how does technology play a role to make sure from a data point of view to help at the subnational, national level. what kind of data support is necessary. And I'll walk us through a few areas. So in terms of innovations, we're looking at it from the product's perspective, the service, but also the planning. How can innovation and technology help in that way? From a product point of view, Gavi has an initiative called the Immunization Uptake, Scale and Equity for Immunization. It's called Infuse, and it's really a way that we can bring in new technologies with governments, with partners, to begin to look at the potential ideas that could help, and help from various angles. And I'll speak to one called Simprints, where, as you know, with a baby, when they're born, you can't really get their fingerprints. What we realize is that even though we're working in the low-income countries, there are children that are born each year that are missed. And these children are what we call the zero dose. That means they're not been to any health facility. No one even has them in the system. So if you're going to go and find them, it'll be a missed opportunity if the health worker doesn't, one, get their data and put it not on paper, but into a system that speaks to the centralized, health system. So by us getting the fingerprints, it's called Simprints. The technology allows you to capture that child, but also it allows for the follow-up for the health facility. The other area that I want to highlight is called Paysetters, where we're involved in supporting logistics, Logistimo. And then the other aspect is district health information software. This has been rolled out in Gavi-supported countries. But another area that I think is really key is not just about the delivery, but it's also the planning. How do we support the health workforce in terms of supporting them for leadership and management? So we do have a program called the Expanded Program on Immunization, Leadership and Management, which has been rolled out in about 15 countries. It's where there's an exchange between academic institutions and the EPI programs, just to really empower the health workforce. But the other things that we are really looking closely at is hearing from the governments that we work with. I think technology is one thing for us to say that we found this new technology, we think this could work in your country. But the other reality is hearing from the governments themselves, and what are they asking us that they need support. So in terms of vaccine delivery, there are some new technologies that are coming up that we believe by 2030 will be viable. So this is the microarray patches, whereby if you go to a hard-to-reach area and you may not have the right health workforce, this is a patch that you can just put on the child that administers that intervention. So with cholera, we're seeing some results with that response. And we're likely to see with measles and rubella by 2030 for the MAPS to be rolled out. The other aspect that we're looking at is really novel technology. We all are familiar with drones. And in 2019, we were engaged in one of the drone deployment in Ghana, whereby using drones to, first of all, it was blood delivery, and now it's been scaled up to deliver vaccines. So we're seeing that to deliver routine immunization, but also possibly into adolescent health, HPV vaccines subsequently. The great thing about this deployment and this approach is that it allows us to really get to really hard to reach areas. The technology is very simple. The healthcare worker doesn't really have to understand how the drone operates. From one point, when you send the product, they just press a button and send it back. So it's a very easy flow, but we've seen that this is a great approach to help in terms of vaccine delivery. And then the other aspect that I think is really key is still, again, remembering that the health workforce are key players. How do we support them with the planning? So there is some technology that we are part of and we're supporting. It's again to focus on the hard to reach areas. Big data analytics to sharpen the accuracy of vaccine delivery, because we want to make sure that there's more efficiency and there's more accuracy and timely decision making. So this level of technology allows us to do that. But I also want to highlight in the next I also just want to highlight that the next phase of Gavi's strategy will begin in 2026. We are trying to reach 500 million more children, and I think that's the reality of the countries where we work. Kids are being born, but the number of children who are missed is quite high. And in this region alone, Asia Pacific, there are about 3 million that are being missed. So that means there is no vaccine, they haven't received anything, they're not even connected to a health facility. So for us, we're very cognizant of what can we do, what is helpful. Technology has a role to play. Governments are asking for us to help support where we can in terms of efficiency and accuracy. But I think looking at the conversation that we're having today, for us, the end user is the child. How do we deploy whatever service and intervention that can help that child? But what is the best way for us to accurately find the child, document the child, but also support the system? It's not one or the other. And I think, Keisha, you said something about what's the problem. The problem is there are children that are missed. Can technology play a role? Yes, they can. What is that aspect is equity, because if we know children are being missed and we do not deploy what we can within the model that we have of a PPP, then us as citizens are missing out. We're not doing the right thing, if you hear where I'm coming from. So I just want to start off with that.
Yeah.
Thank you.
Thank you so much, Chioma. So I think it's really important that you mentioned that we need to be very mindful where we put our resources and that we are not responsible for widening the equity gap. If you invest in a technology that's really expensive out there, but yet you are allowing children to go with 0 dose, I don't know how it's that, how is that a world that we want to live in? So on that sombering note, I think we probably have something a little bit more cheerful. So I have the pleasure of actually introducing Dr. Chayathon Limapamavic, who's the Director of Innovations and Strategy at the Thailand's National Innovation Agency. It's a strategic foresight and innovation expert. So please uplift the mood a little bit more and share how technology that considers community engagement can actually really become operationalized. Over to you.
Hi, good morning, everyone. Actually, I'm from a National Innovation Agency. My organization have a role to promote innovation in the public sector and private sector as well. So the point that I would like to share with you is come from the different aspect, because my background and experience is not in the area of directly to the medical or the health system, but when you talk about the public about harnessing technology to achieve equitable health outcome, from our experience, we found that sometimes technology alone cannot achieve to the market because they cannot turn the innovative idea to impactful outcome. So the way that we would like to create the impactful outcome, we believe that innovation journey is something that's important for any developer, any researcher, or any students. In the last 5 years, NIA worked closely with Thai Health Promotion Foundation to promote the health innovation journey with the student and also researcher as well. When we talk about the health and wellness transformation, we believe that health and wellness transformation is not just about technology to solving the problem with health and wellness. But actually, when we talk about transformation, there are many aspects that we need to integrate into the transformation. Basically, we believe that for the health and wellness transformation, 2 key aspects that quite relate to the transformation is the first one is about social equality of health behavior. Social equality of health behavior is about how an individual health behavior are influenced by various factors across multiple levels, from the individual to the policy to the community relationship as well. And another aspect is about health and wellness ecosystem. Health and wellness ecosystem is about the collection of stakeholders and factors that contribute to the good health. So last year, my organization have done a study about futures of health and wellness in Thailand 2033. We try to use the foresight technique to identify the driving force for the future transformation of health and wellness. And we can identify 6 key driving force that we think have the high impact to the health and wellness ecosystem in the future. The first one is about health actualization, how to make people recognize and turn the recognize to action for health prevention, for health care. The second one is about proactive public health system, how to make the public health system work proactive in terms of the prevention rather than just taking care of a patient or medicine. The third one is about health space and wellness design. This one is about the designing the environment and atmosphere to be good for health and wellness as well. The fourth one is about public health and crisis response. This one is about the preparedness of the government to respond to any health crisis. The fifth and the sixth one is about technology advancements. It's about the AI, the personalized healthcare. As you can see, amongst driving force, only two rely on technology advancement, but the rest rely on the active action and also preparedness and prevention of the society. So basically, we believe that to achieve equitable health outcome, we need to let the researcher, developer to learn about how to turn idea to innovation. Because technology have a critical role, important role for the ideation, it creates something, propose something that can solve the problem. But when you would like to develop to a solution, you need to develop prototype, how to make your prototype sustaining as a product. So in this state, the most important thing is about the collaboration with the stakeholder in the ecosystem. And in the end, if you would like to shift from the development state to the innovation state, you need to think about how to make it run systematically. So scaling up and make a systematic change to the ecosystem is quite important. And we think that the key point is about the business model. When we talk about business model, it's not about making the money. It's about making business operation viable to the market sustainably. So this is some example for the healthcare project or startup in Thailand that develop some solution or innovation for the healthcare system. This one, the application called Pharmacy. This is the first Thai drug search engine with AI image recognition technology. This one aims to use AI image recognition technology to apply with the pharmacy one to recognize unknown pill and identify the pill. For this project, they collaborate during the development process. They collaborate with 7 pharmacy university faculty in Thailand. Pharmacy students come to join during the machine learning process because during the machine learning process, they need experts to come to help to make the machine learning. And also for this project, they get the support from Microsoft Azure to support the system as well. This is the point that collaboration is quite important for the development state. Another example is about business model. This one is the mental health fitness application that developed by startup company. At first, the startup company would like to develop some software that can be benefit to the society in the area of the mental health. But in the end, they find that they cannot run their business based on the funding from the donation only. They need to create their own business model to make their business can run sustainably. So apart from the application that they allow any people can use for the application, they need to equip with the clinic platform, analytical platform. This one need a design to make money from the organization that have a capability to pay for them to run for their own business. So this is another point that I would like to mention about the business model. Sometimes technology, we would like to do some good thing for the society, but technology need money to run. So the company need to design the business model, or any project need to design the business model to make it run sustainably as well. So 2 points that I would like to highlight is about the collaboration and business model to turning the idea to innovation. Thank you.
Thank you very much, Dr. Chayatan. I think that was a really important point to raise. So I think we cannot keep depending on external donors or even internal, domestic funding to sustain such interventions. So they need to be catalytic, and we need to really think about a business model that can operationalize technology. So for now, I'm moving over to ADB, so a funding organization. So Alexio Esperato is a senior health specialist at the Asian Development Bank and has worked across Latin America, the Middle East, and Asia, focusing on health system strengthening with institutions like the Gates Foundation, WHO, and the World Bank, And Alexia will now walk us through ADB's strategy for digital health. Over to you.
Okay, thank you everyone for being here. It's a pleasure being in the session. For starters, ADB is a regional development bank, and our three instruments to help our member countries are loans. Think of very big projects, grants, and then technical assistance projects, right? So technical assistance projects is where we do, as the name says, technical assistance, knowledge, and so on. So when it comes to to digital health, we do have a few strategic guidance documents. Here you can see two of them, which I'm going to discuss briefly. The first one is the Digital Technology Directional Guideline, which essentially provides an overview of all the activities that the ADB sectors, health, education, social protection, and so on, should be doing on digital health, and these include developing sector-wide digital health strategies, doing country readiness assessments, and then at the country level, developing institutional capacities of member countries on digital health, which is a massive challenge, as we all know, promoting knowledge sharing on digital, mobilizing public, that is also ADB's own resources, as well as the resources of the member countries, as well as private resources for the digital, leveraging the technical assistance for individual development, that is our technical assistance, the third instrument that I mentioned, and then using strategic knowledge partnerships. We also have a guidance note on digital health. This is more of a how-to manual on deciding on which specific technologies and developing IT projects, right? And it rests on something called the Digital Health Impact Framework, which I think was developed by the World Bank. And essentially, it would make us go systematically through several dimensions to assess, to choose between different health technologies. And this can be, by the way, part of a loan project or whatever it is. The first one is ensuring that the proposed technologies are aligned with the national and with the digital health strategies. Secondly, assessing the socioeconomic benefits, that is the health costs, societal costs and benefits, and ensuring value for money. Also projecting the future extra capital and operational cash flows, ensuring that the capacity or the enabling conditions are there, and if not, which ones have to be built and therefore costed for, and finally the commercial implications, right? So as we know, in some countries have been using proprietary solutions, and suddenly the provider jacks up the prices and then they can't afford it anymore. So it's really balancing all these various dimensions, how ADB should decide on which technologies to invest in with their member countries. Okay, so here you can see an overview of all of the projects across all sectors, not just health, that have digital as a stated objective. Now, it seems like a lot, right? 646, but only about 35 of those are health. Now, there is a big asterisk here, right? Which is that we have a lot of projects that don't list health as an objective, but do contain substantial health support. Just to give an example, in the Lao PDR, we're supporting the rollout of electronic medical records in about 50 district hospitals through 3 different loans. Now, none of these state digital as an objective, is just one part of a very big project. Okay, so here I'd like to just give you a very quick flavor of some of the projects that we have been doing. ADB supports both the foundational work on digital as well as specific applications, right, with an emphasis on the first. So for example, in Hubei, China, in the Hubei Yichang Comprehensive Elderly Care Demonstration Project, ADB has supported the development of an ICT platform for elderly care. In Tonga, in a smaller grant, 7.5 million grant, ADB has supported the development of information technology legislation, the development of digital health strategy, and then the establishment of an interoperable health information system. That is the registries, standards, and so on. These are the nuts and bolts of any interoperable health system. In Indonesia, as part of a large loan, a 300 million loan, ADB has been supporting the development of integrated health information system for primary care. And then through our technical assistance, smaller projects, we're doing a bunch of things. So for example, in the Lao PDR, ADB supporting the development of an electronic procurement system, as well as the setup of an interoperability server, an HL7 Fire server. In the Philippines, ADB has been also supporting digital tools to enhance electronic procurement system, as well as the National Data Health Repository, which is, if you want, the big database, the one unified database that should integrate data from both the public and the private systems. And here you have a quick overview of the knowledge products. One of them, which I understand has been widely used in Asia by our colleagues from AEHIN, is the Digital Health Convergence Meeting Toolkit. And I just was made aware that there's actually 2 new products on digital health that just came out this week out of ADB. Thank you.
Okay, in case you were wondering, I gave Alexio a really tough time to make sure he keeps to time. And you did splendidly well with 40 seconds to spare. So impressed. But I think what I mainly took back from your session was the how-to manual and how practitioners can adapt it, but also to think about really the infrastructure that needs to be developed. And it's sort of enlightening to hear that ADB is supporting all those infrastructure development for which technology is then able to reach on. Okay, so now, I was not prepared for you to end so soon, but having said that, which is good, it gives us more time for discussion later on. But, before we go on to panel discussion, and I sort of encourage you to think about your questions, we have the trump card in the room. So we have Suhail Bidani, who's the lead for, I cannot find my notes thanks to Alexio, for digital and AI at the Gates Foundation, who specializes in leveraging digital health technology and artificial intelligence to improve health outcomes in low-resource settings. So, Suhail, over to you on your reflections and your thoughts about this whole, how we can harness technology to achieve equitable health outcomes.
Okay. First of all, that statement of trump card.
For later. Oh no, the word. Okay, I guess the word should be used. Yeah, the wild card. I don't know.
Okay. Sorry, before I just come with my thoughts, I'm very, wanting to just comment on a few things that have been talked about. I think, Dr. Nara, to your point on software as a medical device, the challenges and the sustainability factors, I just want to remind everyone that software is just like another living organism, right? There is no end line that we talk about, okay, we are done and nothing more is required to be done. Just the back-end technology could be changing, which means you need to continue supporting it. And we sometimes just forget that. Right? So just a quick reminder to everyone. Dr. Choma, I love the drone example, and I've been fortunate enough to see some of that work happening in Africa. And 2 things. One, this innovation was tested in the context of development sector in Africa. First, at scale, I'm saying. Yes, you can get your pizzas delivered through drone, but there are more use cases for drones to be used. And I'm really glad to see that that is actually influenced many countries now testing it out, including in India, where it's being done now. It really changes the access component in a big way. And I think that's a quick reminder. Very impressed by the work that the National Innovation Authority is doing. And I did pick one point over there, which was this, and thank you for setting the context, this idea to development to innovation and to scale. And I would want to touch upon the last part of how do you want to take it to scale. And before that, my old friend and colleague, former colleague, Alexo, the importance of just getting that how piece right is very clear. I don't think any one of us are here preaching what needs to be done. I think more or less we all understand that. It's the challenging part of how do we go about doing it. I have a question for the audience, and you've been patiently listening, so thank you. You could just raise your hands. Do you use any app on your phone right now related to digital health, whether for yourself or your family? Okay. I'm assuming the rest of the people are being shy, but that's a good indicator of that usage happening. So India is a unique country. I'll come back to this, right? India is a unique country for me because we have the largest connected set of people in the world. And we also have the largest unconnected set of people in the world. The point on equity is not about just people in this room having access to digital health. It's about the people that many of us here sitting actually are trying to serve. And that component means that we just can't think in a more traditional way of the way we use certain things or certain applications. It's about how that women in a rural place in any country that we talk about, especially low middle income countries, are able to access those services, and how easy is it for them? I have another question for the audience. Anybody who's involved in developing and deployment of any solution, not necessarily digital health, but any solution, tech solution? Okay, great. There are a few hands. We talked about user centricity right at the beginning. Keisha, you talked about it. And this is my learning. I'm not here to preach. I'm sharing what I've learned, and I would love to hear from others as well. When do you think we should engage with the user community when we are developing something? And when do you think we should engage with government if it's meant for scale up through the government platforms? Anybody? You could just shout it out. You don't have to raise hand.
The design phase.
Which is what? Day 0, 1, 2, 3? Day 0. Okay. Okay. Thank you very much. Nothing wrong with what you said, and I would completely agree. If that question is asked to me today, I would not have the same answer earlier. It's day -1 for me. If we can't get that input going from day -1, I don't think we are doing justice, and we are not walking the talk. Everybody says, yeah, we need to have user centricity. But user centricity means you start with that conversation day -1. And even from sustainability, I think a lot of times I've seen great products out with very strong use cases coming to the government after they have piloted it, shown some success, and then trying the government to adopt it. I think we need to just start working with the government platforms much earlier, and I cannot stress enough on this. The target populations that most of us care about, work with, are predominantly service to government platforms, and we just should not forget it. I know my time is up. I want to make one last point, which is actually nothing related to what I said. I want to make a very strong pitch for Gavi replenishment. Gavi, and I know you just touched upon it, you didn't talk about it in detail. Gavi is going through a replenishment exercise. I think the work that Gavi has done over so many years and what it intends to do as part of its ambitions is truly phenomenal. Call to action. We all need to support it in any form that we can, including putting out our voices in support of Gavi replenishment. I just wanted to pause over there. But sorry, this was not intended and not part of the script, but
No?
I wanted to do it.
Yeah.
Thank you.
I like to be challenged. Okay, so thanks a lot, Suhail. So right now, before I sort of get the panel thinking and talking about a couple of questions from the chair, I was wondering for you to think about your questions, and later on, I will start to invite audience to share their questions. So there are 2 mics here, and we'll try to rotate, and we'll try to be equitable as much as possible. So do come up to the mic if you want to ask the panel and ask us questions. You can even ask the audience questions. So I challenge you to challenge us. But anyway, so before that, I thought that maybe we could go back and take a step back. I feel that from the conversations that I've heard today, the real question that we ask ourselves is, who do we serve? What is it that we want to get out of it? Technology is great, but we need to be really mindful of the fact that we need to narrow the equity gap and be mindful not to widen it. So I think some of the points and discussions that we had, there's a lot of funding out there that goes into research and development for technology, but is enough actually being deployed, being sort of funneled into actually the deployment to maintain it, to iterate the technology? So I wonder if the panel could speak about it from your own heads or from your reflections from the discussion today. So yeah, over to you. Anyone wants to speak up, by all means.
can take this one. So I will jump also on what Rahel said about the user-centric approach. I think, so we spoke about regulation. So today, when we speak about regulation, it's almost like a dirty word, but it's a good news for the quality of diagnostic tests for LMIC. When we think about the regulation aspect for software as medical device, today there is no choice than user-centric approach, because when you submit your file, for example, for CE or for FDA approval, the first question that you will have is that show us your formative and your usability studies. And it's the first time that the regulation is as stringent as that about the intended user and the intended setting, which is an excellent news for LMIC in terms of adaptability of the tools for the settings and for the user. It's less good news in terms of affordability, because we are not succeeding to find the best business model to sustain those tools. What we experience, so you asked the question about the funding, research and development versus maintenance and scalability. We did a mapping of the funds that are available for software as medical device or digital health tool, and there are plenty. All of them are covering this phase of research and development because it's more attractive, because it's in the mood of the moment. When we speak about maintenance, there is something that sounds boring because it's more about software's bugs, refactoring, and so the first thing is that, as it was said, the end of the development is the beginning of a new life for a digital health tool, and especially software as medical device. And I think the biggest challenges are coming at that time. So it's very important from the beginning, from the D-1, to keep that in mind. The second thing is about the maintenance and the scalability. You cannot dissociate both of them. You are not going to succeed to scale up 2,000 or 1 million facility or user if your maintenance is not strong enough. So I think we should come back to something more granular in terms of definition of maintenance to highlight how much, if you want to reach the majority of the population that you are targeting, you need to think about it ahead. And finally, it's a thought that we are having. I used to compare digital health tool to any diagnostic test, like physical diagnostic test. It's the same principle, and now with the regulation that we have, it's the same constraints that we are experiencing. There are funding mechanism today for HIV and TB and malaria rapid test, for example. We can talk about the work of the Global Fund on this topic. And so one of the questions that I have for all of you, first my colleague and then the public, is what about also thinking about creating a new funding model specific for digital health tool and adapted to the constraint of digital health tool. And I think it's the good time to talk about it in this revolution that we are experiencing, because let's do not wait until we face this problem to start talking about it.
By all means, I mean, pick up the mic if you have a reflection. I mean, maybe while I have my mic, I want to just, pick up on a couple of points. It's so important when you think about scaling up that maintenance is always being discussed, because there's no point, putting a technology out there only to realize a few days later that it's outdated, that it's not usable. Then you're actually wasting resources because you've spent money to bring the tool out there and now it's not usable or it's not actually achieving the intended outcome. So I think, yeah, that's a food for thought, and maybe perhaps what other ideas the panelist has. And I think while I still have the mic, I wanted to throw this question to the panel, but also to the audience here. I mean, some of you in the room here are assessors. You assess if a technology should be invested in. You assess if a technology should actually be something that you deploy out to the settings that you're working in. How are you then assessing if this tool is going to be equitable? What approaches are you doing? What should we be looking at? How do we ensure that whatever we do are serving the communities that should be served, and that we are actually as we, this whole panel is about. How do we ensure that we are getting truly equitable outcomes? But yeah, over to you. Any brave souls? Come on. Yeah.
I was just waiting for this. There are multiple questions within your larger question, so I'm going to quickly try and address them. First, on sustainability, right? I think we've talked about the financial sustainability. There are other elements of sustainability associated, and again, try to break this down. There are countries which I believe today have resources available at their end to support it. The challenge is different, right? The challenge is, do I have the right set of ecosystem for me to run a efficient government procurement process? And I'll take a specific example here. Many of us are familiar with digital public goods. Many countries, especially LMICs, have adopted some of these digital public goods. But here is a problem. The organizations that can support and maintain that digital public good in that respective country is, in most cases, just one. Irrespective of which country we go to, any government, when it runs a procurement process, requires multiple bids to come in so that they can evaluate and then award. How are you going to solve for this problem, right? Obviously, there are ways. How do you deliberately create ecosystem of partners, system integrators who are well-versed, and there are potential bidders for that thing. The other thing, which again is a realization over a period of time, and it's interesting, and sorry, I come from a economics and accounting background as well. So the Commonwealth countries, especially, there are few of them which still follow line item budgeting. Okay, what does it mean? So when I get, as a government department or a ministry or an agency, a funding envelope, it is tied to a particular element written as a line item, and I'm not carrying the flexibility to use it elsewhere. I think we just need to change some of the things around policies as well on how some of these things happen, because these are practical challenges, and finally, countries that just don't have the resources, and it's fair, right? Not everybody can afford it today. As donor funding agencies that support those countries, we just need to come together. For a long time, we have talked about how to create sustainability. We have not solved for it. And I would urge and nudge institutions like Digital Public Good Alliance to try and solve for these problems, because there is no solution yet. Sorry, you talked about inclusion, so I'm just going to give one small example from India. And I don't know, some of you may have heard, Indian government launched this platform called CoWIN for the COVID vaccination drive in the country. It was a completely paperless process in India. When I say completely paperless, including the certificates, were digital certificates available. And I earlier said we are among the most unconnected people in the world, right? So if only 500 million people carry smartphones and rest don't, and don't either have digital access or savvy with enough to go and do an appointment booking, select a facility, select a vaccine, get your certificate, how are you going to deliver to the rest of the population, right? And which is where you need to start thinking and be a little innovative and creative around it. So all that we did was, we said, hey, every mobile number associated can register to 5 more people, and it could be anybody. It is not just your immediate family. So whether it's the driver in your house, the cook, people who are in some way not as comfortable or could not access it, were supported by the rest of the community. And at the end of the day, India did deliver 2.2 billion plus vaccines using the same platform, right? I'm sure in hindsight, we can think about more things that could have been done. But it's a strong example of how a simple tweak can actually create inclusiveness. I'll pause it.
Just building on your question, I think let's step back and ask ourselves, what are we solving for? What's the problem? From our perspective, the problem is that our end user is that child we're trying to get to. And with that in mind, we have to understand, first of all, what are the gaps? and their basic gaps, especially low resource setting or low income settings, were infrastructural gaps. How do you help that health facility get to that child? It may mean that the health worker has to go there. And in some settings, you find that they have to walk maybe several miles, then take a boat, then walk several more miles. But the other reality is that the product, the intervention, be it the PCV vaccine or whatever vaccine, has to be transported. So how do you transport it in the right way? So these are some of the things that we are also grappling with. What is the infrastructural gaps? How do we solve for that problem? Because the outcome is that in this region, Asia Pacific, the coverage on average is about 88%. So that means there are 12% of children that are missing. And these are the hard to reach areas that you alluded to, where it's very far. So from an infrastructural point of view, what role can technology play in terms of the cold chain optimization? So with Gavi, we do have a cold chain optimization equipment program where they can have like the fridge, which is like a handbag that they use to carry the vaccine. But the other reality is the facility from the point where they left also has to have some sort of energy. So how do you address that? What's the technology? Because it's not just to take technology for technology's sake, but how does technology help solve the problem and create the outcome that we want to see? Then the other thing that is glaring for all of us is that what you alluded to on sustainability. No government is going to spend more money on things where there's no data that tells them this is a worthwhile investment. So what's the data gap? What's the data telling us? What's the data informing us? So these are the kinds of conversations that we're having. And then I think the reality is that it's not the same, countries are not the same, even within countries, the diversity, the context, the geographies. So all of that has to be taken into account. And we are actually looking at AI from the point of view of, okay, we're in this season where there's so much quick technological changes. How can AI come in and help within the immunization space? So there are a few things that we're looking at with DataKind, which is around supply chain optimization, but also micro-planning, because at the end of the day, it's not just about the product or the service, but it's also the healthcare workers. How do we support them to be prepared, to gather the information, to vaccinate, but then also report back in the right way in terms of management? And I think, for us, technology is moving very fast. How do you scale up? Because it's one thing to get new technologies that could be so expensive, but it might not be right for the kind of setting that we're in. But what's the technology and innovation that a country has possibly deployed? Can that also be scaled up to the right way to get more outcomes? Thank you.
Yes, I would like to add another point in the case that we would like to narrow the gap about the equitability in the health system. In the innovation development area, we're gonna have the term TRL, Technology Readiness Level. It tells us about the level of technology that's ready to the market or not. But actually, there is another term that we need to concern. It's about ARL, Adaptation Readiness Level. Because sometimes when we develop the technology, but the people, the society, they're not ready to adopt the technology yet. So in the driving force that I have mentioned earlier, there is another driving force that's quite important. It's about self-actualization or health actualization. It means that they need people, individual people, they need to have enough knowledge to know about the technology, to know about the consequence of the health problem, and then they recognize this issue and turn to action. Sometimes they can prevent themselves, sometimes they can protect themselves before they're gonna get sick or have an illness. So I think in some area, maybe the funding should go to this area as well to make the market or the individual have higher level of the adaptation, the readiness level as well.
Yeah, thank you. So at ADB, the way that we work, we developed, I guess you could call it proof of concept through our TAs, and then we implement that scale through the loans, through the big projects, right? So to give you an example, in the Lao PDR, we're supporting the linking of an open source electronic medical record with various applications, lab information systems, national insurance system, and so on, through the TA, and then we implement that across facilities, that suite of applications, through the loan. Now, on sustainability, I think this is always the hardest question, I think, for development people, right? The agreement is often, okay, we're going to support through the loan, and then you put it in your national budgets, right? That's often the agreement. It doesn't always happen in real life, right? So, for example, in one country, we were asked to develop a procurement solution because the application that the country was using was paid by another donor, and the donor stopped paying for it, so they can't afford the license anymore, right? And I don't have a clear answer to this. If someone does, maybe you should give them the Nobel Prize of Economics, right? Because this is happening pretty much everywhere to various levels, right? The other part of sustainability that I think is very important is the human resources. Ministers of health in many countries have very few IT people that will be able to maintain applications. We had an experience recently in one big country in this region where, in this case, it was a vaccine tracking application that was it was transferred from the Ministry of Technology to the Ministry of Health, and the Ministry of Health had not put it in its budgets, and they didn't have IT people to take care of it. So they stopped using it, right? So building the capacity of the workforce, not only in the facilities, but also being able to attract software engineers and to maintain them, not that they run away to the private sector as soon as they can, that's another fundamental challenge. Regarding the scalability, the emphasis is often on adoption, which is you talk to the big people in the capital, in the ministry, and then voila, they accept the application and we're going to implement it in 150 facilities. But often what you get is silent pushback from the people in the facilities. Why? Because IT applications can transparentize their problems, or even some practices that may not be very good, such as misallocation of drugs, right? So working with the people from the facilities from the beginning is essential, but it's not how we tend to think, right? Development is a very top-down business. I think that's unfortunately the reality of things, right? How can we find ways to do that? I don't know. One successful example is from my home country in Spain. In Spain, the unified medical record for hospitals did not work, right? So that's fragmented. But on primary care, we do have a unified medical record that is being used across the country. Why was that? Because it was developed from the beginning with the Family Physician Association, right? So they supported it from the beginning, so there was no pushback, right? But again, how we can do that in our context, that's maybe a different question.
Yeah, I mean, you raised an interesting point. You say technology is currently a top-down approach. It shouldn't be, right? Should it be? Should we continue to allow this to persist? I mean, we talked about T-1 or D-1, right? Sorry, the term that was used just now. We talked about diversity. I mean, all of these conversations that we should be having T-1 before you ideate, before you do all of the discussion. So all of these stakeholders. So my question to you, who should sit on that table? Who should be in that room discussing it? I mean, should we then say it shouldn't be a top-down approach? It should be perhaps more open and more consultative, so that you get diverse opinions and you're more inclusive with, getting ideas. Any thoughts on that?
I can take a stab at that. I think for our model is public-private partnership. It's intentional. We have about 23 board, and it's a reflection of the kinds of stakeholders that are needed. First of all, the implementing governments. That's critical. I think the other reality are the partners on the ground, the country offices. Normative for us is WHO, UNICEF, but then also those who understand the technology, if that is what's really being deployed from the bottom up, to really help answer that question about, is this really going to solve my problem? Is this really going to help further the positive outcome that we want to see? And I think the other reality is, does this align with the national, for us, is immunization strategies or the program and the direction of travel for the government? Because the other reality is sometimes there are certain vaccines where you need to maybe, and I'm sorry, I'm going to be a bit technical, where there's one dose and a second dose. But if the coverage for the first dose is not high enough, it's a signal that you're not ready for whatever new technology you want to deploy. So there's that aspect of sustainability, efficiency. So at the table, we should have that diversity of stakeholders that are key. And I'll speak to one of the vaccines that we support, human papillomavirus vaccine. This is for adolescent health. Even though it's health, it requires also education, Ministry of Education. So you might have to bring another line ministry into the conversation with government, or help encourage that inclusivity. So I just wanted to share those thoughts.
So I'm going to put the panel, you're going to still have to answer that question, but while we wait for the panel to answer, please find the microphones. Just walk to the microphones, queue up there, and we'll take about maybe 2 to 3 questions at a time. Okay, so panel, come on, my stakeholder question. I think you have a lot of opinions, but
I think it's a global discussion in health right now about the patient-centered approach and how we make the patient owning their health and being the expert of their health. And I think for digital technology, it's the same. It starts from the patient. For example, there are questions that we faced in countries and it was very interesting to discuss with ethical board in different countries, like in Mali, in Senegal. One of the questions that came is that, okay, we will be testing clinically for the performance of this tool, but then once it's used in routine, are we going, for example, to ask for patient consent, even for the diagnostic, in routine diagnostic when using this tool? Are we going just to provide the information to the patient that's part of his diagnostic was performed using a technology or using AI? And there is no answer, clear answer, or a universal answer to that. And I think it's part of the ethical questions that we will have to ask ourselves, even as individual, as a patient. I wonder sometimes if my diagnostic is managed by an AI technology. I want to be informed. So I think it sounds a bit naive, but I will still think that patients are the first target or stakeholders who should be involved. And then when we speak about user, it's the workforce, the health workforce. And something interesting was said about how when we introduce that technology, we can have resistance from the workforce because you highlight what they were not doing properly. We experienced that in Yemen, for example, where we introduced the tool, CE marked, validated, everything is fine and things. And we undermined this aspect. And they refused to use the technology because they were challenging the technology. Because they were saying, yes, but before, it's not the diagnostic that I was doing. And so I used to say, they don't know that they don't know. And in our approach, for the introduction of such tool, and that's why one tool is never going to resolve all this problem. It's a program, it's things that are around, it's capacity building, it's e-learning that comes with those tools in order to reinforce the capacity of the human resources so they don't feel that they are challenged by the technology, but they feel that together with the technology, they can learn and they will provide a better care for their patients.
So I just want to make a small point, and I really like something you called out. So if you do a landscape of digital health solutions across the world, you'll see 70% of plus of them today still are addressing administrative needs in the entire hierarchy of reporting. And to the point that you just called out, by using that as a punitive mechanism is the worst thing you can do. Because eventually, the user is going to figure out how to game the system, and this entire exercise is going to be a futile exercise.
And I think actually a lot of this was what Dr. Chayatan raised earlier, like knowledge, literacy, and I'm going to throw in back what the panel mentioned earlier today, empathy, and also the fact that there's active action, and that approach has to always be, ground and center. Okay, thanks so much. Oh, Alexio, you want to say something?
No, thank you. Yes, so I totally agree, right, that the transparentizing of data should not lead to a punitive process, and this is exactly what generates pushback from the facilities. Yeah.
Thank you, thank you. Okay, so audience, please introduce yourself very briefly and then give us your question as short as possible. We'll take 3 at a time. So maybe we'll start with Taufik first. Sorry, Taufik.
Okay.
Maybe you can introduce yourself.
Thank you. My name is Taufik Jordar. I'm an associate professor at Singh Health Duke and US Global Health Institute and also a board member of the Health Systems Global. So we are here to talk about equity, right? To achieve equitable health outcomes. Now, equity doesn't mean that you reach only the poor. That's a good thing, but that's not equity. Equity means you address the disparities that are avoidable and unfair. But when you introduce a health intervention, a technological intervention, you cannot prevent the rich people to go there and get it because this is good. They have all their privileges and everything, they will use it. That eventually means that the rich people are going to use this good technology. You're not preventing them. You cannot prevent them. And eventually the disparity is increasing, which is not helping the inequity situation, right? So as a decision maker, what would you do specifically to address the question of equity so that this disparity is decreased and also, of course, the rich people are getting benefited? Thank you.
Okay, Omar, maybe a question from you?
Yeah. So while talking about equity and health delivery systems, if we were to look at health systems as an user and understand that most of the health systems in our context that we work in are fragile. So I'm just going to use a very crude example. If one of our users was visually impaired, we would design for that, right? It would be a voice-centric application. Similarly, if our health delivery systems are having impairments in the way it is currently functioning, wouldn't our approach to design be totally different? Because quite often when we design for something that is very controlled for a perfect product or a perfect innovation. Do we really take into consideration how our health delivery systems are? And second part of that question is, how do we give voice in this whole process of equity? So that's been end users, people who are in the margin. How do they interact with our platforms and have a voice to inform how service delivery failures are actually addressed?
One more question from there. Maybe introduce yourself. Thank you.
Okay, thank you so much. My name is Niyi Oshamilui from Lagos, Nigeria. I run a digital health consulting company, and I'm also the convener of the Africa Digital Health Summit. So let me say thank you, first of all, to our incredible panel and our moderator. So my question/comment is in 2 parts. First of all, most donor-funded projects are patterned in a way that the donor reaches out to government. Government tells them their needs. Then there is the design, development, and deployment of that solution. So how are donors thinking about support, management, maintenance? Most times, the platforms that are built are usually version 1. There will be version 2, 3, and 4. How are they thinking about this? So the subsequent iterations, like you mentioned, and support, management, and I say this from experience working with government. So that's the first part of my question. The second part, specifically, I want to thank Suor Bidani, Alexo for his talk about the lack of finance and capacity within ministry, development work being top down, and Chema talked about PPPs. Another talked about, can we think about a new funding mechanism in digital health? So I want to invite development partners, funding agencies, donors, to consider rethinking how we support digital health. So I live in Africa. In Nigeria, for example, we've got fintechs that are unicorns, that like we say, unicorns, that's companies that are worth over $1 billion. Are there things we can learn from finance in health? There are big companies in finance. In Africa, Kenya, there's M-Pesa. So what can we learn from finance in health? In health, I know a lot of times the private sector is in another room. in the main room, they are the development partners and the government and the implementing partners. But you find out that in finance, you have a lot of the private sector doing incredible things. So my suggestion is this: is it possible that funding agencies, they consider funding the environment, governance structure, guidelines, and things like that, rather than not necessarily applications? Is it possible that they focus on building the environment, regulation, and things like that, rather than the actual applications? For example, if you want vaccines, most likely you will go and meet the private company, Pfizer, etc., and you will focus on maybe supply chain logistics. You wouldn't try to create a factory to build the vaccines and stuff like you would go and meet the private sector. So why don't we focus on the environment and then possibly, potentially consider partnering with private sector for digital health? How can they deliver and then we can begin to talk about scalability, sustainability, because most of the time, private sector has got this built into their solutions. They are thinking scalability and sustainability. So to summarize that part, can we potentially have this funding going into the regulatory environment, going into things like governance structure, capacity building, rather than funding actual solutions? Thank you.
So maybe just to summarize, there's the part on addressing disparity to ensure that when we talk about equity and making sure that even the rich can actually access the health system delivery, how do we ensure that the voices are heard from those who are not always being heard to? How are funders thinking a little bit more about patterns, iterations? How are you going to redesign the way the funding model works? Should we be rethinking how we support digital health innovations, and actually the importance of really listening to private and also private non-health sector as well? What can we learn from them? So anyone who wants to take any of these questions?
Okay, so maybe on the question and comment from the last gentleman, I totally agree with him, 150% actually. I think that the development partners, and including the multilateral development banks, we should be supporting the architecture of the system, the policies, the regulatory. The tension that we always have is that, there's always someone who will come with a cool application, right? And can you support it? And that comes sometimes from the governments themselves. We have been doing this, hard work of helping countries develop policies, standards, protocols, figure out the architecture, set up interoperability service, and so on. The challenge that we sometimes have is when I go, for example, to ask for funding to support this kind of work to our, believe it or not, we have our own funders that we have to apply to get funds, okay? This kind of work is often fuzzy, it's confusing, it's not sexy, right? It doesn't get people excited, right? What gets people really excited is, oh, we're going to implement some really cool mother-child artificial intelligence-based sustainable application in country X, right? And that can be a real hard battle, right? To get the buy-in from our donors so that it doesn't sound to them like, oh, we're just going to be doing a bunch of meetings in the capital. And in the end, nothing concrete is going to come out. But, I totally agree with that. We're doing it in some countries, and I wish we were doing some more of that work. The other challenge that we found on the ground is that a lot of this hard, unsexy work of, again, developing IDs, registries, software, the architecture of the system, and so on, is being done already by other development partners. And then it becomes this big thing of, who is doing who, and who's going to take care of what. And that can lead to tensions also. Yeah.
I would like to add another point about the funding model, because actually, from my point of view, when we talk about the funding model or financial model, we need to balancing between about centralization and decentralization. Because for the centralization, basically we try to make it more effective because we have a limited resource. In the case of Thailand, for the basic research, we try for the funding at the basic research, we try to centralize it because we have limited resource. We cannot invest in every technology to develop. But in the case of innovation, we try to decentralize it because we found that when the technology is ready, many private sector, they are very welcome to adopt or adapt with their business. Or even it can apply to some community that have capability enough to invest by themselves. So for the market and innovation, sometimes the doing in the approach of decentralization, collaborate with the partner around the private sector to invest is much more effective to make it diffuse to the market. Yeah.
Can I just add something? So I'm totally sharing your thought about and your thought also about the funding and the fact that maintenance is not at all sexy, and it's not what the funders are looking for, because they want to be visible and they want. I think something that we need to think about, and I don't have a solution. We are facing this issue today with the antibiotic and its maintenance, but we need to think also about the argument that we need to highlight to the funder about the business model. Again, I come back to the example of physical diagnostic test. If you want to produce 2 or 3 different rapid diagnostic tests for COVID, malaria, or TB, you need 3 different manufacturing lines, which means that you multiply your production cost by 3. Which is not the case for digital health tool. Today, for example, I have a regulatory team and I have a clinical team working on one software as medical device. If tomorrow we add a second one and a third one, it's the same team who is going to work on those. So the production line are more streamlined and are cost effective compared to the physical diagnostic test. So I think what would be interesting is that we open also the discussion altogether about what are the arguments and what are the case and the file that we can build in order to find arguments that talk to the funder, which is the cost effectiveness. And it makes maybe the things sexier.
I just wanted to come in on, not that question, but I think on the voices of the end users. And one thing I want to emphasize is that the community perspective and the community voice, civil society are critical, pre, during, and post. And I'm speaking from, the immunization program implementation, consulting with them and understanding again, what is their need? What is their ask? And bringing that into the forum, because we don't do what we do on our own as Gavi, we do it with government. So creating, if there's no space for civil society, how do we create that space to bring them in and to have a say, and in allowing them to bring their context, because they truly understand their community. They truly know how to get to that, that child, that family where it's probably a nomadic, family that moves around. The other thing around voices is oftentimes civil society must come with the problem and they keep going on the problem, but what is the solution? So that's another thing that when we talk about voices and community, please encourage them to bring that solution, because they have the innovation, they have the context, they understand their landscape. And I think the third thing for us that's critical is that when it comes to the annual reviews of immunization programs, it happens once a year. It's called a joint appraisal, where everybody's at the table to discuss what was success like this year. For next year, if we want to reach more children, what do we need to do? And there's a plan. So the other reality is that if those stakeholders are not in this kind of forum, they need to be in that forum. And if it's a situation that's closed door, there are partners who can help, open the door or, be a step in for them. And I think the other question I just wanted to touch on is what you said, Professor. I work in the public policy space, and policymakers are key, and that's legislation and legislators. And the disparity of the rich, the haves and the have-not it's in many countries. The question now is, what is the best forum to scale up in X countries, not the same with Y? And this is where before deployment or introduction is, what's the kind of committee makeup so that they can talk through some of these sensitive areas, so that it's not like one group is being supported and another isn't. So that's what I would say. But what does a national, for us, is the immunization program or strategy saying? Because for us, it's children, and it's not children because they're rich or children because they're full. It's this birth cohort we're targeting. So a rich family can come and still get the intervention. So I would say, let's look at the policy first to understand, does the policy articulate it in a position that is for one group versus the other? If so, how do we address that inequity? And again, that's for me is legislation. So thank you.
Okay, I'll try to cover all the questions that were asked. I do have a viewpoint on all of them. Just on the private sector point, I think we are continuing to get inspired by what happens with the private sector. I don't think we are doing enough to work with them. And by that, I'll just give quick examples, right? So whether it is recharge using, USSD then got applied in multiple ways, right? So in India, we have QR code-based payments. It's called Unified Payment Interface. Today, the same thought process being applied on in a public hospital, how to scan and share to get yourself registered, for which, by the way, people used to start queuing 4 hours in advance because they were not sure whether they'll get an appointment today with a doctor or not, right? Which is simply a scan and share today. So there are multiple such examples. But when I said we are still not solved for, or we are not doing enough working with them, again, I'm just taking India examples because one of the most astonishing thing for me in India over the last 2-3 years has been the delivery platforms in India. I mean, I don't know in Thailand what's the situation in your respective countries. Today, I could order a shirt or a phone. It will be delivered in less than 12 minutes at wherever I am. Literally less than 12 minutes. And we are yet to solve for vaccine delivery and drug availability in facilities. So there is a lot to be done. I'll tell you the challenge. Not that we've not attempted. I think the challenge is we've not cracked what is in it for that business and how does it align with their goals and objectives. Because at the end of the day, let's be very realistic about it, right? They're a for-profit entity responsible for increasing the valuation of their shareholders. That's always going to be their first priority. We have to find a balance on that. So point taken, I think we need to do more. I'm going to quickly address the disparity question and the voice of the community together. My personal view, it's an intent question for me. I don't think it's anymore a technology question. In fact, with AI, I think what we could do today was unimaginable even 2 years ago. Today, you could get millions of your actual users give you real feedback on real time because translation transcription technologies have advanced so much. So I can just synthesize everything in a matter of minutes. It's not even hours. So we just need to get that intent going. And finally, on disparity, I completely appreciate your point. And I'll call to action, right? And I don't know how many government representatives are here, but at least organizations like ours who work with the government, we will continue to nudge. Any development of any digital solution needs to ensure that it is not just about economic strata, it is not just about gender as a perspective. It talks about differently abled people, to the point Uman also made. There are standards which are available. It's not that we've not defined how this needs to be done. We just need to put that in our requirements document very clearly and make it mandatory for every single solution that comes up going forward. What has happened. We should change that as well. But can we just take a simple call to action, say, these standards will be part of the requirements document that the respective vendors going to look at before they start development. That's it.
So one small comment on whether the funders could reconsider supporting maintenance. Funders are actually a choir of voices. It's not just one voice, right? And if we want to support maintenance, we get almost immediate pushback from 3 groups, right? The first one is financial management, right? They often tell you, we don't support maintenance straight. Or after digging for a few months into this, I found out that it's not encouraged, right? But again, all you need is one department to not clear your project and the project cannot go ahead, right? The second group that will offer resistance is procurement. Okay, and procurement is very powerful in multilateral development banks. Why? Because maintenance often needs flexible funds, right? So I just developed a TA for medical equipment management, and one problem is, machines break down, you need to buy spare parts that would cost $3, $5, $10, but you cannot predict how many spare parts for which specific machines you're gonna need over the next year, right? So then you need flexible funds, right? And the potential for those funds to be used for other things is big. So therefore, the procurement people and the financial management people will say, no, we cannot do this. The third actor is the governments themselves, often the ministries of finance, right? They don't like it when donors are supporting maintenance. So given all of this, you just have to get really creative. And sometimes you're able to somehow pull it through. Sometimes you're not. It goes on a case-by-case basis. There are some people, there's a book from Angus Deaton, a Nobel Prize in Economics, and one of the criticisms that he made of the development industry is that the development industry pushes governments to build more hospitals, more schools, and so on, without giving any thought to their maintenance, right? And that's a cultural change that is required, but it's not just the sector people, it's other departments, and even in our member countries, the ministries of finance themselves.
I mean, like you mentioned about the need for flexible funds and the spare parts. I mean, can you imagine having a car and then your tires are completely punctured, and then they tell you, sorry, no, we're not going to replace that tire. What's the point? You spend so much money buying the car. I'm so sorry to make you laugh. Anyway, I just wanted, before I go on to the next set of questions, I just wanted to thank the audience who are still standing, and really we'll come to you very soon. But to those of you in the room who cannot, for some reason, stand for so long, please find a way to let the coordinators know, and we'll make sure that we take your questions. We also want to be equitable in that part. So over to you first, maybe. Yeah.
Thank you very much. I'm Cheetah from Asian Development Bank. I have a very specific questions regarding the regulatory framework and regulations, especially to NECA. So as you all know, the regionalization and the harmonization of the regulatory framework, especially for the pharmaceutical products and diagnosis product, is very important. And Europe, so they have a well-established regulatory bodies, EMA and some other. ASEAN is very the beginning, so because the ASEAN, there is a regulatory framework in 2023. My specific questions is especially to Nada for the Middle East. What sort of mechanisms, regulatory framework in terms of regional, and what sort of technologies that can harness these regional, the collaboration as well as the regional harmonizations to strengthen the regulatory capacity? Thank you.
Thank you. Maybe next question and then next one.
Good morning, honorable speaker. My name is Thiracho Swanvilaikun. I'm a third-year medical student and a part of IFMSA Thai chapter delegation to PMAC today. So in Thai context, the universal health coverage, or UC, it's like one of the most important building block in having a good health outcome, as it ensures people access to the healthcare. But as a medical student, we learned that there is a lot of controversy and question going on about the sustainability of the coverage in Thailand. So I seek your experience and perspective on this matter, and I want to ask what might be a good leverage point for technologies and innovation to come and tackle this potential risk of system failure, to ensure that the coverage is still working, but to ensure that the coverage is still working, and to ensure that the health outcome of the Thai people will work well in the future. Thank you.
Sorry, I was just admiring the eloquence of a medical student, so it's really good to see. So basically the discussions, I was trying to figure out the two dimensions that we are trying to look at, and these are mutually reinforcing. First is the equity of digital health technologies, and then there's another, which is the equity of outcomes through digital health technologies, which are very different but also reinforcing. I think much of the discussions is around equity of digital technologies, the digital enterprise plans and all these things. But I think along the vein of reacting to day -1, do we actually have a digital health development agenda that is shaped based on the health system fragilities and barriers in terms of where we don't have human resource, where we don't have finances, where we don't have health information, and where we don't have commodities? And if so, if we have that, was it actually shaped based on the advancements of the technologies, or was it shaped based on the status of our equity? So hopefully that's something that we can also work in within the region.
Is there two more questions? Two more questions. Maybe just one more then. I'm so sorry, honey.
Yeah, has been really standing for a long time. My name is Fuji Su. I'm from Duke Kunshan University in China. So I wanted to go back to this at the beginning of this today's conversation. Dr. Naida, you highlight beautifully the gaps in access to IVDs. And so my first question is, do you have any news from any panel to address that gap? Like almost half the population don't have access to diagnostics. I know there's 88% for Gavi, is still a space to go, but it's like for IVD, we are catching up, I think, so anyone has any suggestions how to address that gap in diagnostics? My second question is specifically to Dr. Naida. I have a good news to share. At the Duke Kunshan University, we are working with Gates Foundation to help the manufacturers of diagnostics to bring their product to developing countries and challenging places. But the problem is legally, right? So the regulatory approval process, I wonder, you have been working in the very challenging places, and you have any insight to share with us how we can help collectively the manufacturing, different sizes and shapes, from different part of the world, developing country or developed countries, to help to address the gap of diagnostics. Thank you.
Okay, so I think we can sort of summarize. Hani, is your question fast, or would you want to, Dr. Hani Kim, do you want to also address your question? Because I don't want you to keep standing for so long.
Yeah, actually, if I can just quickly add one question, because I think it really picks up on a point raised by the gentleman before me. So he asked a question about whether there are any. My question is directed to the panelists representing the Thai National Innovation Office. And the question is, when you and your colleagues prioritize what to fund, which type of innovation you are going to fund, and what kinds of innovation that you deprioritize. How often do you actually sit down with colleagues from other ministries to really look at your priorities with that equity lens? In other words, to ask yourself that which of these innovations will truly actually help the most marginalized working class families in Thailand? Thank you.
Thank you. Okay, so I think just very briefly to summarize questions on regional regulatory frameworks, or maybe even just regulatory frameworks. So a couple of points there to Nada and the rest. UHC and system failure, what are we doing about it? And I think the point that both Hani and Mix was trying to address was really on digital health agenda. And when you sort of think about how to prioritize and deprioritize, how are you then deciding? Do you speak to the other ministries about equity? And I guess equity from the point of view of technology, but also equity from the point of view of outcomes as well, right, Mix? Yeah. Okay, over to you.
I can start with the boring regulatory aspect, because that's how we used to see it and present it. During your question, you said that in Europe there is a regulatory framework. In fact, it's a struggle because it's a new regulatory framework. It's a new regulation since 2022, much more stringent, and because of that, there is a lot of diagnostic tests for LMIC that are not anymore manufactured, because the manufacturer, they select the cost-effective diagnostic test, and usually it's not for the LMIC market. So we are experiencing a huge crisis in terms of discontinuation of some of the diagnostic tests because of the application of the IVD regulation. The other challenge that we are facing in Europe is also the lack of notified body. It's always the same. So regulations are put in place, but the means to implement the regulation are not available. Today we have 11 notified body, and I can tell you, for example, that the waiting list to be audited for a CE mark is a minimum 2 years. And I'm not going even to enter in details that we are experiencing. You imagine as a non-governmental organization, a humanitarian organization, we are CE marked, and now we are transitioning to the IVDR. When you look to the cost of the certification, the number of audits, and the cost of each audit, and the impossibility to negotiate with the notified body on those costs, especially if we are talking about non-profit organization. In fact, the conclusion is that if we don't accept their condition, then our product is not going to be certified and therefore not available on the market. So I think there is a problem also here in Europe regarding the application of regulation. So just to say, I'm not sure that Europe is an example today regarding the new regulation for IVD. The good, let's say, news about this regulation, and so there is the IVD, but I include the AI Act. But the good things with the IVD regulation is that it includes everything: the regulation about the AI, the regulation about the data protection. So it's quite comprehensive. So the good news is that from at least our perspective, we think that it will decrease some of this inequity regarding the quality of the diagnostic tests that are available. For a long time, and we observe that within MSF, we purchase diagnostic tests for the countries where we intervene, and there is a suboptimal quality compared to the one that are available on the high-income countries market. And so today, with this unique regulation, both from FDA and CE, because there is a common, let's say, basis between those two regulations, it's not possible to introduce on the market, on the LMIC market, those digital health tools if they are not manufactured. Now, so this is the good news regarding the quality. The bad news is that the regulation is still not adapted for LMIC. What the requirements that are put in this regulation, and I can give you an example about clinical evaluation, clinical performances. So we assessed antibiotic performances with the intended population in 5 countries: Yemen, Jordan, Mali, Senegal, 6 countries, Kenya and Laos. And so it's a huge clinical trial, huge multicentric clinical trials. And so when we submitted our file and we were audited, the question from the auditor was, why, for example, you did not standardize the consumable and the reagent across all those countries? And for us, it does not make sense, because if you want the real performance in real condition with the constraints that we know in our settings, we should not harmonize the practices across those different countries and different continents. Otherwise, you have theoretical performances, and that's exactly what creates the gap between what the manufacturer is saying in the AFU and the reality in front of the patient. So I think there is also a point to make on the need to adapt this regulation to limited resource settings. We are talking about that for IVD in general since a long time. Nothing is moving. I think there is a wish and there is a hope, at least, for digital health tool and for the regulation for software as medical device. This morning, during the plenary session, there was a discussion about that, about are we going to create a regulation for each country? This is going to be impossible. And then how are we going to be able to develop tools that can be implemented and scalable in different countries? The solution that was provided, or at least the idea that was shared this morning, is that we did that for human rights. Like, we don't have to agree on everything, but we have to have a basis that is common. And this base that should be common, it should be between high or low and middle income countries. It's the same, because we are just talking about quality of those digital health tools. So I think there is something to be done on this. And there was another question that was, sorry, about, about the gap. The Middle East, no, there was a regulatory for Middle East. No, there is no regulation, like global regulation for Middle East. But there are strong countries like Jordan who has their own regulation, with the Jordanian FDA that's doing an amazing work. And so far, what is applied is still a CE mark or FDA approval framework for IVD. And then, yes, unfortunately, more than 40% of the population does not have access to diagnostic today, and we are still experiencing that. There was a hope that after COVID, everybody, the world understood how much diagnostic was important for health system. I think now it's going down, and there are other, let's say, sexy topic that are taking all the attention. The good news, and maybe good news and a bad news, we are seeing a kind of collapse of health system, of high-income countries, some of the health system. We are seeing also a demographic shift. And so all the studies show that the weakest parts in all the care path is the prevention and the diagnostic. And I think more and more studies are showing that how much we will decrease the cost of the treatment and the burden on health system if we increase the funding and the efforts on the prevention, vaccine, including vaccine, and the diagnostic. And I think in front of this economic crisis that we are experiencing regarding health system, we don't have the choice to switch in our mindset regarding prevention and diagnostic. It's a wish.
Yeah, no, thank you. Yeah, so the question on the, how to sustain the healthcare system in Thailand, I used to be a student of the Thai health system. I haven't been so for a few years, right? But for me, Thailand, as long as other countries like maybe Sri Lanka before the crisis, Colombia and so on, are countries that achieved fantastic results with very limited funding, right? Now, in any health system, the most cost-effective interventions, I think we all know this, are in primary care and prevention. There is also a set of hospital-level reforms that come out of European countries because of aging, what Nada was referring to, that are starting to be implemented in Latin America, and these focus around care integration, right? These include, essentially the objective is to keep patients out of the hospital as much as you can, right? So they include things like ambulatory surgery, what we call day hospitals in Spain. So some patient has a hypertensive crisis, the specialized unit that will stabilize the patient and send them home rather than admitting them into the hospital. Things like case management that actually comes from the US, and then the integration between social and clinical services. Right? I mean, this may be a way. Now, some of these reforms are not very easy to implement. Regarding the question from Mike's from ADB on, equity and how to ensure that applications reach the poor, more than thinking about, and I don't know if I got the question right, but more than thinking about this or that application, probably the key is, as there are 2 billion people that have no internet connectivity in this world, is to first think about how to expand that connectivity, right? And that often requires very basic things such as electricity supply, right? So electricity, devices, expanding broadband, that happens over time. Probably digital literacy, and in some countries there's large segments of the population that cannot read or write, at least in the country's national language. So using things such as pictorial pictorial rather than written text and so on. But probably the key is expanding connectivity first and trying to remove some of the social barriers, such as why does the boy have to get the mobile phone and not, not the girl or the mother, right? Okay, I stop here.
They're better qualified people on the first couple of questions. I'm just going to talk about diagnostics. I don't know the cost of doing a RT-PCR test here. Anybody? Or if you've not done it in the recent past, how much was it last time around? So in US, if you have to do it, I think will still cost you about $150. If you want a result in 24 hours or 48 hours, you have to shell out another $50, $100. I don't know exactly, but upwards of $200. It's a good example for me because when the pandemic hit, India actually didn't have any RT-PCR kits. And obviously we had to get it going, manufacture. The first set of RT-PCR kits had to be imported. By the end of 2020 itself, we were not only serving the requirements of RT-PCR kits in India, but exporting it. By third quarter of 2020, we were paying less than $6 for that test to be done, RT-PCR, not antigen. And we continue to have the same pricing point, right? The reason I'm highlighting that is that this affordability and accessibility problem is actually deep-rooted in not just manufacturing happening in the geographies where we need it, it's also about shift in the research and development investments also moving to the geographies. So just wanted to highlight that. The other thing which was brought out, not directly, but this point on diagnostics not being affordable and other things. I think given that there's so much conversation that we've had over the last few days on AI, and one interesting part of or use case of AI, which is going on is predominantly in the screening space. And I want to reiterate, we are still talking about screening in most cases, not diagnosis. Unfortunately, when you go to speak to many of the policymakers, their question is, how does it compare to the gold standard I have? That gold standard is on diagnosis, not on screening, right? So I think we need to start thinking differently on how do we want to leverage technology. Yes, I'll be concerned if there are a lot of false negatives, but I'll be less concerned on false positives because this is still not diagnosis for me, right? We just need to enable that environment and leverage technology better.
Yes, I would like to respond to the two questions. The first one is about the universal health coverage. I would like to add another comment that I think the most important thing to support the universal health coverage is about the health prevention. I think the most important thing is to let our people learn about, focus more about health prevention rather than health treatment. But it might take time to, before it's going to have the effect to the universal health coverage again. And the second point for the question about what is the criteria or what is the way that we use for funding the innovation project. As mentioned, when we talk about innovation, sometimes when some technology ready to apply to the market, but sometimes the market is not ready to adopt the technology yet. So another aspect that we use a lot for as a criteria to screening the innovation project is about the adoption level of the society. When we talk about the adoption level of the society in the healthcare system, I think there are two main key stakeholders. The first one is about operators. Sometimes operator is the public sector, sometimes operator is the private sector. But the operator have a capable enough to run in the long run, have a business model, have the operation model to run sustainably. The second stakeholder that quite have important for this one is about the user. Sometimes even the operator are ready to operate, but the user don't have enough knowledge and embrace this technology to their life, to their treatment. I think it's sometimes quite difficult to create the market. So this is the main aspect for NAA as a criteria to provide the funding to the innovation project.
I'd like to just respond to the universal health coverage question from the gentleman. I don't know the Thai health system fully into the details that you have in medical school, but I can speak from our perspective working in low-income countries. Immunization, as you know, is a fundamental, it's a platform that leads us to UHC with primary healthcare and then UHC. And some of the learnings that we have is that really it's around planning, but it's also around the budget, around what are the essential services for prevention. Because the vaccines that we support are really preventive measures. You don't want that child to come to the hospital with pneumonia. You don't want to have a measles outbreak. These are the preventive measures, and it's planning ahead, but also having that kind of financial allocation conversation, ministries of health and ministries of finance working together, looking at the present, but also planning. For us, it's a 5-year cycle. We have a 5-year strategy. The current one will end, the next one will start in 26. So working closely on that. And I think the other aspect is just for you to be aware, which you might already know, at the World Health Executive Board meeting next week, universal health coverage is one of those topics of discussion. So I think if every level, low income, middle income, high income, are continuously speaking around this issue, it will help us speak to, one, the preventive measures, but also some of the context in this region where you have an aging population. What do you do to support them? So those are just some of the insights that I wanted to share. Thank you.
Yeah, thanks. Calm down, Alexo. Don't worry, we have 5 more minutes. I noticed that you guys are so scared whenever the bell rings. Yes, football game, indeed. Okay, so I'm now going to tell the panel, think about what your 30-second key message are based on the discussions that we had, the presentations that you've made, and maybe even the discussions that we are not having, that we should be having. But to think about what you want to say in 30 seconds, because the timer is running. Maybe 45. Okay, give you a little bit extra. But I'll start. So while you start planning, I'll start. So I think we stress the importance of regional regulatory frameworks. So the importance of harmonization, but also the importance of being flexible, because you need to really address the local context and the local issues. I think it's also important to think about technology being affordable and accessible, and really to take this idea, I mean, there are so many tools out there for screening, but how do we actually do gold standard diagnostics? And also when you think about diagnostics, are you then able to link them up to proper care? So which is then the next point of, do you have the trust and the buy-ins of the operators, of the healthcare workers, of the other ministries that are important, but also more importantly of the private sector? How can we better leverage private sector involvement in this whole development? The last point that I wanted to really stress upon here is that knowledge is really important, literacy is important, and also, how do we get people to empathize with the technology that's being used and the people that they are serving? Okay, next, anyone, any brave soul who wants to go next? 30 seconds. Lexo, yes.
Yeah, so probably my take home is to focus on the boring stuff. I think that IT creates a lot of excitement to a lot of people, but the more that a person knows about IT, the more of a nuanced perspective that they have, in my experience, right? The less of it as a silver bullet that they think of it. And there's probably 2 things that are key. The first one is investing in connectivity in electricity, particularly in rural areas. This is the basis of everything. And this very obvious point very often goes missing in conversations. And then the second one, which is probably a call to organizations like mine, is focus on the boring stuff, okay? The setting up of unique IDs, systems, patient registries, facility registries, data warehouse, data protocols, data architecture, and so on. Because otherwise, you're gonna end up with a health information system that will contribute to fragmenting rather than integrating the health system?
I would say, in fact, the technology is just a tool. It's not a solution to the health problems that we are facing and the inequity that we are facing. And the second thing is, as I said previously, I think we are in the middle of this revolution. It's not too late to think about how do we rationalize the use of the resources. And so let's ensure that we are developing solutions that are going to be helpful for the population in the long term.
I think I have a few thoughts on this. first of all, just to build on what Nada said, what are we solving for? What's the problem? And ultimately, who's the end user? Our end user is both the baby, but it's also the parent that brings the child. Then another end user for us is the health worker. So how can we make sure the solution is, one, both cost effective because of the settings we're in, but also how do we scale up? And then I think the word that we've heard quite a bit is maintenance. How do you maintain this? And then ultimately for Gavi is the sustainability. How do you allow the government or that health facility to fully take it on and take on the ownership? So yeah, those are my few thoughts. Thank you.
My point that I would like to highlight is, I think, about the innovation. I think for the health system, it's very, very complicated system. And I believe that for the innovation, the first thing, we need the collaboration, because we need to include our stakeholders to join during the development process. And the last thing is about the putting some creativity to the operation model. Because when we would like to deploy or diffuse some newer solution to the larger context, I think we need creativity to the operation model to make it work in the society.
Okay, I feel pressurized. 21 seconds. Inclusion and sustainability, to start from the ideation stage, keep thinking about it. Related to it, we need to invest more in data and evidence gathering. I think that's important. The one thing that we did not discuss actually in detail, but I really like the point on that voice of community feedback loop coming in is really important.
Yes. Can I now invite all of you to thank our panelists for the interesting discussion? Thank you, audience, for your interesting questions. And also thank you to the organizers for really this wonderful facilitation. They were able to get me on the timer really well. So kindly take a moment to complete the evaluation form provided. If it's a paper form, please drop it in the evaluation box located in the front of the room after the session. For electronic submissions, you can actually scan the QR code provided there over there. So we really value your feedback. Do give us some constructive ways to improve and be creative, right? I think that's the key.